This is Correctional Officers Awareness and Training on TBI in the Prison Population by Jamie Stackhouse, Sierra Reed, and Caroline Foreman.
Our areas of interest include traumatic brain injury and the chronic symptoms associated with TBIs, male inmates in the prison population, and correctional officers and their training modules.
The purpose of our study is to determine the level of general knowledge on TBIs that correctional officers have. We want to create an effective training module which will provide education to correctional officers on both the signs and the symptoms of TBI, and also find a way to reinforce appropriate ways in which these professionals can interact with this population.
The questions we are answering are: how much correctional officers currently know about traumatic brain injury, how effective the use of a training module is when given to correctional officers, and how the use of a training module changes the way correctional officers view and handle male inmates who have sustained a TBI.
For our study, we will be giving a pre and a post survey. The pre-survey will determine level of knowledge a population has about TBI, and the post-survey will determine how much they have learned after given the training module. First, we would like to target a student population at UNCG and pilot the training module on them. If the training module is effective and generates both reliable and valid results, we would then like to generalize and adapt the training module for correctional officers.
Before we begin, here is some background information on traumatic brain injury and the prevalence of TBIs in prisons. Each year, more than 1.4 million Americans sustain a mild to severe TBI. Currently, more than 2 million people reside in U.S. prisons and jails. According to the Center for Disease Control and Prevention, 25 to 80% of inmates report having experienced a head injury or traumatic brain injury. Based on these numbers, if at least 25% of inmates have experienced a TBI, then that means more than 500,000 inmates have sustained a traumatic brain injury. Prisoners who have had head injuries may also experience mental health problems such as severe depression and anxiety, substance use disorders, difficulty controlling anger, or suicidal thoughts and/or attempts.
So I looked at a systematic review, and it was called Neurobehavioral Sequelae of TBI, and it was done by Riggio and Wong back in 2009. And as far as the methodology is concerned, the literature that was used in this systematic review spanned from the years 1966 to 2008. So there was a total of 259 article abstracts that were reviewed for this systematic review. It's important to note that the interpretation of literature of neurobehavioral sequelae of TBI, or NBS, is a challenge because there are significant flaws in the designs of most studies. For example, many studies didn't include a control group to compare data to, and there was also no assessment of the patient's health pre-TBI, which is extremely important. Knowing premorbid mental and physical health is extremely important because it allows the researchers to delineate signs and symptoms that occurred because of the TBI, and then those that were already present due to comorbidities. As far as pathophysiology goes, lesions due to TBI can be seen as primary or immediate, or secondary, so damage following insults. Injury can also be characterized as focal or diffuse, meaning contained to one area, that's focal, or throughout, which is diffuse. All patients reported NBS in the acute phase following injury. 30 to 80% of patients who have suffered a mild to moderate TBI report NBS symptoms for up to 3 months post-injury, while approximately 15% of mild patients have NBS that persists beyond 3 months. NBS post-TBI is categorized into two main categories, neuropsychiatric and somatic. So falling under the neuropsychiatric category are both cognitive and behavioral, and we'll get into some of those a little bit later. Some risk factors that may aid or persist NBS development are gender, so females over males, advanced age, prior diagnoses that are effective in nature, such as anxiety and depression. Next, I want to talk about neuropsychiatric symptoms. So it's important to understand that there's a lot of overlap between cognitive deficits, behavioral disorders, and somatic manifestations. This is why treatment and management needs to be individualized because manifestation of symptoms changes from person to person. It's important to understand how the loss or newfound difficulty of an ability can affect multiple parts of a patient's life, including social function and ADLs. Under neuropsychiatric symptoms, we have cognitive disorders, which are deficits that may include attention, memory, and executive functioning, including but not limited to sustaining attention, planning, switching between activities, organizing, and sequencing. Due to this, a patient may have difficulties completing things that they had been able to do before, which can be frustrating and can result in irritability, anxiety, apathy, and depression. Also under neuropsychiatric symptoms, we have behavioral disorders. Behavioral disorders can be the result of psychiatric disorders or may be secondary to other processes such as problems with cognition or medical and structural lesions. The challenge in this category is for the physician to determine if the presenting symptoms were there before the injury, and if so, if and how these symptoms played a role in the injury. Some changes that can be seen under this category include, but are not limited to, personality changes, which may include aggression, impulsivity, and irritability, which can be either verbal or physical and can be expressed as verbal outbursts or combativeness. Also, emotional lability and apathy. Major depression is also under behavioral disorders as well as anxiety disorders. PTSD and substance use disorders are also very common. Now I want to talk about some of the somatic symptoms. So some common somatic symptoms include headache, which is the number one most commonly reported somatic symptom, dizziness, nausea, vertigo, fatigue, sleep disturbances, seizures. It's really important to determine how having a TBI can affect those, especially when we're looking at the prison population, and if you work alongside them. So if you're a correctional officer, all of these things may have a large impact. For instance, if I don't get a lot of sleep at night, or if I feel a lot of fatigue, it affects my emotions and how I react to situations and people. So it's important for correctional officers to know how to handle these signs and symptoms if they're presented and what strategies are effective. So some of the strengths of the systematic review, I'd say the greatest strength is the depth and variety of information regarding the signs and the symptoms post-TBI, which was made possible due to the large number, 259, of article abstracts reviewed. So some limitations were significant design flaws. So as Riggio and Wong said, failure from a lot of designs to use a control group and no assessment of premorbid mental and physical health. Under the disclosure section of the review, the authors list potential conflict of interest, which could be seen as a limitation if there is any bias for or against sources or information. And lastly, while it has significant clinical implications, there is such a large variability of symptoms and their manifestations, and this changes from person to person. So what may have a negative impact on one person may not on another. So if anything, this review should show the importance of performing a thorough evaluation on each of the clients that you see, each of the inmates. It's good to know their case history. That's where the most emphasis should be, and also those symptoms that were present prior to the patient's TBI. So in conclusion, Riggio and Wong found that both the evolution and resolution of NBS symptoms over time is multifactorial, so dependent on many factors and largely variable on a case-by-case basis. So they determined that an individualized and coordinated multidisciplinary approach is necessary in order to create both an effective diagnosis and help with the management and treatment of the NBS symptoms. So that's my spin on this review. I thought it was great, and I think that it's really important for correctional officers. If they saw this, they could see all the possible signs and symptoms, under which category they fall, and they might then be able to understand how to go about dealing with them. So these will be some things that we tackle in our training module for those correctional officers.
Results from this study showed that in the 9 months after the first training, the number of total incidents, number of incidents involving use of force, and incidents of battery by bodily waste on the special housing unit all declined significantly when compared with the 9 months before the training. The number of all incidents declined from 162 to 84. The number of incidents where force was used by offenders declined from 148 to 81, and the number of battery by bodily waste incidents declined from 14 to 4. Usually, once offenders who sustain a TBI are placed in a prison facility, they do not do clinically well. But this article was chosen to highlight the positive changes and benefits that can result from providing staff with the proper educational training to work with these individuals. The strengths of this study include the very detailed curriculum, the full staff training, and the objective data reports provided prior to the NAMI training. On the other hand, the study's weaknesses include the lack of a control population, the self-reported data, and the lack of control over the environment. The administrators created their own monthly reports, so the researchers just had to trust that they were fully accurate with providing that information. Also, as expected in a large prison facility, there were a number of changes that were implemented in the Indiana Special Housing Unit before, during, and after the NAMI training. So it leads us to wonder if some of these changes could have contributed to the decrease of incidents as well.
Jennifer Bogner and Dr. John Corrigan conducted a study to assess the test-retest reliability as well as the criterion reference validity of the OSU TBI ID, which is an assessment protocol that was designed to combat problems of reliability and validity of self-report as well as to adhere to specific definitions of severities of TBI as outlined by the CDC. They chose a random sample that was equal parts male and female and also represented a variety of ethnicities. All of the participating subjects were English-speaking consenting inmates. The inmates were told that they could refuse to meet with the researcher without penalty. Parts of the mini international neuropsychiatric interview were administered as a screener to rule out schizophrenia and psychosis. The 210 subjects reported a combined total of 529 TBIs, which results in roughly 2.5 TBIs per subject. They took the results of OSU TBI IDs administered and computed the principal component factor extractions with both principal axis factoring and maximum likelihood rotations. They used a backward selection modeling technique, which resulted in a reduced model where they then tested the interactions between variables. Lastly, they conducted a diagnostic test to detect collinearity. Overall, the results were very supportive of the psychometric properties of summary indices from this evaluation method. The conclusion was that the indices related to self-report of childhood TBI and length of time that consciousness was lost had lower reliability, but still fell within an acceptable accuracy range. However, the indices related to recall of more severe incidents as well as those based on counts, excluding multiple mild injuries, tend to have higher reliability. Development of a reliable and valid method of eliciting an individual's history of TBI is a mandatory step to determining the prevalence of TBI in prison populations. It is hoped that a tool that meets these high reliability and validity standards will prove useful for identifying avenues for support and intervention, including training of correctional officers on the signs and symptoms of TBI and how those lasting effects may impact how they handle this population. The strength of this study include the large sample size, that it was a random population, use of a single standardized assessment, and the diversity represented in the sampled population. The weaknesses include all of the potential biases, including that the inmates who participated may differ from those who did not in an important way. The diverse population is a strength but also a weakness as this was a test of an evaluation method and was not designed to give population-based estimates. Generalizability may be an issue as it was not conducted on inmates who require higher levels of security. Lastly, there's always the problem of retrospective self-report.